Welcome to the Red Flags webinar. This is extremely important. If you're here live, I commend you because Monday you're going to have some patience and something that you learned today might walk in tomorrow. And I know it will be available recorded on AccuVids, but there's no time like the present. No time like the present. So what we're going to do, what the point of today is there's 4 goals that you need to learn. 4 goals. One is at the end of this webinar, you will know how to look at a condition and know when to refer it out as soon as possible. You'll also know when to look at a condition and know it's something you can't treat. And you'll know it's something you can't treat because it won't look right. You see, we don't have to know what this red flag is, but what we do have to know, we have to recognize that it's not normal. And remember this, there's one quote I'm going to give you. I know I gave a lot of quotes. The one quote is, when in doubt, refer out. When in doubt, refer out. The last thing you're going to learn is predispositions of certain red flag conditions to certain types of patients that have certain types of illnesses. This way, we can prime ourselves. Should something walk in the door, we could say, yes, that person has diabetes. They're more susceptible to cellulitis. They're more susceptible to, they just had a fracture. They're more susceptible to bleeding that could cause compartment syndrome. Okay, so let's really keep that in mind and let's enjoy it. This is going to be something. All right, let's get started. So the 7 different red flags we are going to cover, or the 7 different concepts we are going to cover, are infections, obvious symptoms of aneurysm and meningitis, blood clot, deep vein thrombosis, embolism, the difference between costochondritis, or having a rib out, and a pulmonary embolism or heart attack, myocardial infarction, how to diagnose, this is going to be a really, really cool one, how to diagnose stroke from Bell's palsy. 2 similar conditions, similar clinical presentations, but succinctly different assessment tools. Complications of fractures and complications of muscle injury. So it's all going to tie together. Yeah, and when you have questions, if you can put it in the Q&A, how we normally do, and then I'll address them at the end of this webinar, this webinar is probably about 55 minutes or so, and then we get into the Q&A. Okay, cellulitis. This is infection. This is going to be the most common red flag that you will see. To date, in my practice, so it's like halfway through 2019, I've seen 4 cases of cellulitis, 4 cases of infection. The recent one was Monday. Had a patient who was bitten by a dog, and they went to the doctor and it didn't look too bad. The second day they came to me, that I was treating them for a different problem, and they had all of the symptoms. Infection of cellulitis is caused by strep or staph infection. Does it really matter what causes it when they come into your office? No. What matters is that we recognize it. The signs: redness, warm or hot, tender to the touch, and painful. In extreme cases, patient has fever and flu-like conditions. I've actually drawn on my arm what an infection will look like. So I'm going to come up to the camera. Can they see that okay? Under the light, can you see the distinct difference there? All right, so if I stand here, what happens, this is my normal skin. This is what it will look like. This is makeup, okay? So I don't actually have an infection. I wouldn't be this calm if I was. No, I'm kidding. I'd be calm. I'd be a little bit more agitated. I wouldn't be doing a webinar. Anyway, this is what it looks like. All right. It looks distinctly different. It's tender to the touch. It's warm. When I mean warm, I mean you could hold your hand back here and you could warm your hands. And the last one, of course, it's painful. So what do we do? When we see this, what do we do? What we do is we get a marker. Can everyone see this is a marker? This is a highlighter, a 2-in-1. So this is the marker side. We get a marker, and what we do is we stencil around it. all right? I'm going to stencil around it and then tell you why. We stencil around the border very gently. Make it right around that. Why do we do that? Because after I stencil it, I tell the patient, okay, you're going to go to your doctor, you're going to go to the hospital, the urgent care facility, you're going to get antibiotics because you have cellulitis. And when they get there, sometimes they may say, well, I'm going to go tomorrow, or they go later that day. If it spreads, if the infection is outside the confines of my stencil, the doctor who they see will say, hey, this has been progressing, this is an infection, you're going on antibiotics. Conversely, it works the other way. After they're on antibiotics, typically they'll get stenciled again, and they'll see as it decreases, as it gets smaller and smaller and smaller. So make sure you stencil it, because it shows that you're responsible, and it shows that you're concerned and you know what you're doing when they go to the ER. Anyone who has this, even if it's not an infection, we know it's not normal, and you've done the responsible thing by referring it out. What can this be confused with? This is why when Josh and I first talked about this, is because a lot of people think they see this and the person says, I have elbow pain. And they're like, well, that must be muscle inflammation. And they go about and you treat it like you would any other thing. No, you can't do that, because muscle inflammation doesn't look like cellulitis at all. Muscle inflammation is internal. You can get joint swelling, and this is another one, joint swelling. Out down here it says gout. So gout is a buildup of uric acid crystals in the joint. If around a joint, like an elbow or a big toe, there's all these symptoms, tenderness, redness, heat, then it might not be an infection. It's probably gout, but either way, it doesn't matter, because when in doubt, you refer out. Even if it was gout, you're not going to treat it because you're not sure if it's an infection or not. Emergency medicine, there's one thing about conventional medicine, and a friend of mine who's a medical doctor told me this. Emergency medicine and the conventional medicine is good for one thing, really good at one thing, treating emergencies. Outside of that, we know their track record in treating low back pain or musculoskeletal. Look, it stinks, okay? Any other chronic condition, not that great. But you're having a heart attack, you're having a stroke, you have an infection, instantly, the emergency medicine can help us the fastest. So I know we're in our individual disciplines and we've been learning different things, but when we have the red flag, we refer out because we have to do what's best for the patient. Infection. Some risk factors of infection, lymphedema. So anyone who has an immunosuppressed system, obesity, the studies have shown that obesity increases the chance of infection. People with diabetes, so capillary fragility, so blood vessels that are weak. And then any skin puncture, we look for a point of entry, specifically someone with an immunosuppressant system, a scratch, a bite mark from, in this case, the dog, or an insect bite, things of that nature, that will aggravate it. Speaking of dogs, right on cue, Nitro walks in. Of course, he has 4 teeth. Right, Nitro? You open doors now, eh, bud? Okay, great. Just close that there, yeah. Of course, the treatment, you stencil, you refer out, and then it's antibiotics. So, aneurysm and meningitis. So, again, we don't really need to know specifically what aneurysm and meningitis is. We have to recognize the symptoms. Aneurysm is a blood vessel that bursts in the brain. Meningitis is an acute inflammation of the nervous tissue that encases the spinal cord. Both are medical emergencies. Both can present with sudden or severe headache, stiff neck. Now, there's other ones here we're going to get to, but if someone walks in with a sudden severe headache and a stiff neck, whether or not they have a fever, refer out. Because they're the top 2 symptoms of either one of these conditions, refer out. Better safe than sorry. Other associated symptoms, of course, you'll have nausea, vomiting, fever, specifically with meningitis, blurred vision, seizure. Of course, in most any case, someone that has an unexplained seizure, you would call 911 or you'd get them assistance. And then this is, they include this loss of consciousness. Anyone loses consciousness, definitely get them help. Now, this is different from fainting. The last thing I talk about is fainting, because fainting or syncope is something that happens. It's not that uncommon. That happens during an acupuncture treatment. So things we can do to address that. Not that, push that button off, the battery sheet's flashing. Just hold it to shut it off. So anyone's coming in, sudden severe headache, stiff neck, we refer out. You won't see that too often, but the more patients you see, the greater chance you are to see it. All right. We're going to talk about blood clot, DVT, deep vein thrombosis, and embolism. First, what is a blood clot? And this is the interesting thing, because when we think of a blood clot, we don't think of it as in terms of injury, but injury has a lot to do with it. A blood clot is solidified blood that fails to dissolve in the blood vessel post-injury. Now, post-injury doesn't always mean someone's injured like in a sport. Post-injury means someone who has plaques, fatty plaques, atherosclerosis in their blood vessels. The blood vessel is constantly trying to reduce the inflammation, the damage in the artery itself. That's recovering from an injury. Smoking causes damage in the arteries. That's post-injury. A fracture, someone breaks their leg, the blood vessels have to repair themselves. A muscle tear, the blood vessels have to repair themselves. So people who have other things going on, like diabetes, who have capillary fragility, blood vessel fragility, are at greater risk for things like a blood clot. Definition of terms, DVT, a deep vein thrombosis is a blood clot that occurs in the deep vein of the leg or the arm. That's why they call it the deep vein thrombosis. And embolism is a blood clot that blocks flow to a vital organ or any organ at all. You can have an embolism to any organ of the body. The liver, most common, are the brain. And the most common one you hear about is a pulmonary embolism, is the lung. Now, very important. What are the risk factors for blood clots? Obese. Studies, in fact, the studies show, recent studies, that the taller you are and the heavier you are, the greater chance you have to have a blood clot. And the reason is there's more of you. Okay, the more blood vessels you have, the greater chance something can go wrong. People who smoke are higher risk of blood clots. People on oral contraceptives, people older than 60, people with chronic inflammatory diseases, so diabetes, bowel disease, autoimmune diseases, congestive heart failure, atrial fibrillation, cirrhosis of the liver, cancer, fractures, sitting a lot, and frequent air travel. So a lot of patients might fall into the sitting a lot and frequent air travel. So it's very important to tell your patients who travel a lot to use things like compression stockings, to make sure they get up and they walk a lot, that they stretch, because what happens as you sit, the blood itself stays in the major arteries like the femoral artery, and it can actually clot. Because what does blood do that doesn't move? It clots with platelets, and it can become immobile. So we always want to keep moving. Any flights over 4 hours, make sure you move around and walk around, or have seats with extra leg room. That's why aisle seats are the best, because it's easier to get in and out. You can stretch out your legs, especially if you're tall. And as well, stand desks here in Canada are quite popular. They're desks that rise up so people can sit and stand, so they don't have to be sitting 8-10 hours a day. They can spend more time on their feet. All right, let's talk about the blood clots themselves when they manifest, which I've had in my career, 17 years, I've had 4 that I can think of that I've sent to hospital. So they're less often. You can see infections, I've probably seen 12 or 15. 4 just in this half year, and the deep vein thrombosis. All right, so what are the symptoms? The symptoms of the deep vein thrombosis are swelling in the ankle, calf, the lower leg, with cramping, tightness, and as well, there are signs of infection. Warm, hot, red, tender. Now, here's the thing. A lot of, during this webinar, whenever you see PA, that means physical assessment. It means it's an opportunity to exercise your physical assessment skills to help determine. And I'm mentioning this, and then I'm putting a caveat to it, because anytime I deal with a DVT and I see swelling in the ankle, foot, or calf, and it's hot, and I think it might be, I don't touch the patient. In fact, I stand like 4 feet away from the calf because I don't want to do anything, touch it, or do anything that might dislodge a blood clot. So I myself recommend against feeling the pulse. And this here this is the foot. Can they see this okay? All right, this is the Achilles tendon. Remember, this was in the plantar fasciitis webinar. This is the posterior tibial artery. If you feel behind the tibia, so that's in the inside part of your ankle, you can feel a pulse, okay? Someone with a blood clot, there's a decreased pulse, because what is a DVT? What is a blood clot? It's a blockage of the blood vessel, the blockage of blood leading to an organ, okay? So as well, in a blood clot, you can even look at the foot itself or the nail beds and see what the perfusion, the capillary refill is in the nail beds themselves. So what that entails, and this is my nails, is you press the nail and you release. You press and see how it's white, and does the blood come back right away? That's a sign that the tissue is getting perfused. Another sign, without even touching the patient, if the extremities are turning kind of a bluish color, okay? If that happens, just send them to the hospital. They'll do a Doppler ultrasound, and they'll figure out whether it's just a strain or there's a deep vein thrombosis. If patients are obese, if patients have chronic inflammatory disease like diabetes, there's a greater chance they have it, so be aware of that. Embolism. So embolism, again, what is an embolism? It's a blood clot that blocks blood to an organ. In this case, we're talking pulmonary embolism. Pulmonary embolism is classified as shortness of breath, chest pain, increased heart rate, and increased breathing. And again, we see this PA. So what's great about this is that if someone comes in with shortness of breath and chest pain, it takes 15 seconds to take their pulse, okay? And the normal heart rate for a pulse is 60 to 100 beats a minute. Take it for 15 seconds, multiply by 4. Breathing is regular respirations is 12 to 20 breaths a minute. If they're panting, if you can tell they have chest pain and shortness of breath, refer out. Other things associated is actually a cough, or a cough that produces blood, of course. Now, this is not costochondritis. The other thing I do with patients, and I just booted up my Apple Watch here because I shut it off so it would preserve the battery on the phone, but the Apple Watch is fantastic because what it can do is sometimes, if I'm not sure, I had a patient yesterday who was having a bit of an anxiety attack and whatnot. I put this on their wrist because the health option on it really is extremely well detectable. In fact, in a recent study, the Apple Watch, not the number 4, this is the number 3, the lower version, can actually is 97% effective in detecting heart irregularities, heartbeat arrhythmias, irregular heartbeats, 97% regular, 97% accurate. In fact, the number 4, and I haven't seen this, this is the crown of the watch, the dial. You can put your finger on the crown and it takes an ECG of your heart. Think of that. And so the technology is amazing. But I'm just saying, you have it at your disposal. If you use it, use it. But again, someone comes in with shortness of breath, chest pain, increased heart rate, increased breathing, because if you have shortness of breath, you're going to have increased breathing. Call 911, make sure someone gets into a hospital right away. CC means costochondritis. We've seen it a lot, especially if you're chiropractors. You've seen it a lot because patients come in and say, I have a rib out. And usually a posterior to anterior thoracic adjustment clears it up, or a local needling to the paraspinals clears it up. We're working the motor point right over the area of the erector spinae, no problem. But costochondritis, people will describe it as having a rib out. And essentially, it's a muscular strain with some joint dysfunction at the rib articulations. So essentially, right off the center of the spine. They'll feel it, and it'll be painful with deep breaths in. For example, this is someone with costochondritis will say, take a deep breath in. I'll be like, they'll be like, oh, it hurts when you take a deep breath in, okay? Someone who's having a heart attack, an MI or embolism, has breathlessness. So it's not just pain with the breath in, they have pain all the time. I can't catch my breath. They're sweating. Their heart rate is up. They have chest pain, pain down their arm. Now, with costochondritis, you can also have some chest pain and pain down the arm, but it's less distinctive. Someone comes in with breathlessness, sweating, increased heart rate, just call 911, all right? Or make sure they get to a hospital. Again, you can check the heart rate, you can check the breathing, but remember, when in doubt, refer out. All right. Now this one is pretty cool because we see a lot of Bell's palsy. Anyone who practices acupuncture sees Bell's palsy because Bell's palsy responds very well to acupuncture. So what happens here, if you just pass me the skull right behind you. First, let's define what stroke is and what Bell's palsy is. Thank you. Stroke is a blockage of blood to the brain. It could be from a blood clot, which we just talked about, or it could be due to a burst blood vessel, okay? Wherever, if it's in the neck, wherever it may be, it can cause a stroke itself. A Bell's palsy, however, is temporary paralysis of the facial nerve. Now, you remember the TMJ webinar? There was another webinar that I did. This is the skull. Can they see that okay? Mm-hmm. All right. So the facial nerve, where you'll find the facial nerve, this is just great because we can look at the anatomy. This is the TMJ, okay? The facial nerve is actually right behind the angle of the mandible. It runs in through here and then it branches out. And it branches out to the entire areas of the face because they're facial nerves. So of course the nerves go to the face and they're responsible for facial expression. So let's talk about a patient that comes in with a stroke, and let's talk about a patient that comes in with Bell's palsy. When someone comes in with either Bell's palsy or a stroke, they have drooping of the face. So if their face is drooping like this, whether they're having a stroke or whether they're having Bell's palsy, you're going to see the exact same thing. The difference is when you see that, and I do this, even patients come in and say, oh, I have Bell's palsy. I don't treat them for Bell's palsy. I first rule out the stroke because it's an easy test. I say, okay, raise your eyebrows. Do this. Okay? And close your eyes. So ask them to raise their eyebrows. See that? Raise my eyebrows. And close both of your eyes tightly. Because someone who has Bell's palsy can't do that. If someone with Bell's palsy comes in and they can do that, refer them out. Because the facial nerve is working. The facial nerve is not working. It's paralyzed. And typically, the paralysis in Bell's palsy happens at the trunk. It happens down through here. So if it happens at the trunk, then everything on that side of the face isn't working. That's Bell's palsy. If they're having a stroke, we have to think FAST, F-A-S-T. First of all, facial expression. Can they raise their eyebrows? Can they close both of their eyes? If they can, that's a sign that they're having a stroke. Also, in addition, slurred speech, confusion, further validates the fact that they're having a stroke. But for me, if someone has drooping face and the facial nerve works, to the hospital. Time is of the essence. 911, have someone drive them right away. You need to recognize that. And a lot of people don't know this simple test, but this simple test can pay dividends for the patient, for your practice, for your career, for just, you know, so you can rest assured that you've done everything you can. Okay. I'm going to shut my phone off. The Apple Watch. This is what it looks like. Let me see. I'm sure everyone has an Apple Watch. I'm usually late to the party anyway, so this is just, you know, it tells us different things. It's taking my heart rate. Let's see what my resting heart rate is. I have to turn my arm. My arm doesn't bend that way. There it is. That's my resting heart rate. That's not bad. That's 60. You know, that's in Lance Armstrong vicinity there. You know. All right. Enough about my watch. Complications of undiagnosed fractures. Now, this is really cool because people don't think that fractures. I have to know all these problems that can occur from a fracture. Okay, outside of the compound fracture, okay, someone comes in with a broken bone and broken skin and blood, what you call the hospital. I'm talking about fractures that you may not know are happening or that may have happened but haven't healed correctly. All right, so here are things we have to worry about. So there's really 7 different complications of undiagnosed fractures. One is a malunion. Now, a malunion, let's say this is the clavicle, because the clavicle is extremely important. The next webinar, I was telling Rebecca this, the next webinar is another free webinar, July 25th. It's on soft tissue. You're going to see the things that we can do with the clavicle and the muscles that attach to the clavicle. We know we added a clavicular assessment to XDOR with the shoulder. Now there's research showing that it can help improve by addressing the clavicle, the function of the cervical spine. Anyway, I chose the clavicle because if you have a malunion or a problem in the clavicle, then it's going to further cause problems with the movement of the shoulder and their mechanics. A malunion is, let's say this was fractured. This is what it looks like, how it should heal correctly. A malunion is when a bone heals, but it heals crooked, or the alignment is off. Non-union. Non-union is when not only did it heal crookedly, well, it didn't heal at all. It actually healed in 2 or more separate pieces. All right, sometimes this may require surgery. And the reason I'm telling you this, because a lot of times you're not going to see a malunion or a non-union, but you're going to see someone who has a fracture or you suspect a fracture. And the fracture essentially is preceded by trauma, and you have extreme tenderness in the area, lack of ability to move the joint. If that's the case, I would refer out first. Some people say, well, I'm going to treat it anyway. Well, don't, because there's other complications that can happen if you suspect a fracture. Get them to the hospital right away. And this is the other ones. So in any type of fracture here, you have concern in youths, children or adolescents that are not fully developed, that you're going to have damage to the growth plate. So this is the bone. Growth plates are located at each end, and the bone elongates. It grows. And if there's an injury, if that area is fractured, and the longer it stays fractured, sometimes it can stunt the growth of that bone. So just for that reason, if there's trauma, if they're an adolescent, make sure you get them to the hospital. Most hospitals here in Hamilton, they have a fracture clinic. So most bigger metropolitans will have fracture clinics because it's that important. AVN, avascular necrosis. Avascular necrosis is when during the fracture, there's a damage, there's a severing of the blood vessel feeding the bone. And if a bone cannot get oxygen, the bone dies. The bone dies and withers away. This is what a ball and socket, we'll call this the hip joint. These represent the blood vessels. This green represents the fracture. And after the fracture, the blood supply is cut off. After a few weeks, this is what the head of the acetabulum looks like. Probably the most famous person ever to have avascular necrosis, athlete, probably one of the greatest athletes of all time, Bo Jackson. Bo Jackson played obviously baseball, and he played football with the Los Angeles Raiders, and during a game, he broke his hip, and they just thought it was a hip pointer, but in fact, he severed the femoral artery, never played football again. Other complications we have to think about. Surprise, surprise, blood clot. Because we learned earlier that post-injury, clots formed, and when they're undissolved, they can form a blood clot. So someone, of course, you could think about it. If someone had avascular necrosis, there's actually damage to the artery. If someone had a fracture, there's damage to the surrounding musculature and the surrounding blood vessels. CRPS type 1, complex regional pain syndrome type 1 or type 2 can form. So after any trauma, and we are familiar with this with chronic pain, so this was previously called RSD, reflex sympathetic dystrophy. So type 1 means there's no nerve injury, but there is changes in the extremity. Usually happens in hands or feet, where the extremity will become swollen, will change color, will have profuse sweating, and will be 1,000 times more tender than it has to be. Like someone if I had it here and I touch it, they'd be screaming. They have chronic pain. Nobody really knows why it happens, but it's like a blip in the nervous system that causes that part of the extremity, those nerves, to go rogue. They're like vigilantes, and they kind of go off course and like nomads. And this is what happens. It happens in the arm or the leg. And risk factors, of course, injury, traumatic injury, surgery, and the most recent research says people who smoke and have injury or surgery tend to are more likely to develop complex regional pain syndrome. So if they have a fracture, this is another reason, get them help right away. Because this is not something that you can predict, but sometimes it happens right away. This is the other interesting one, because people don't realize, what? From a fracture, all this can happen? This is crazy. It is crazy, but it's good that we're having this dialogue. Osteomyelitis. Osteomyelitis is an infection of the bone. Myelitis means infection. Osteo means of the bone. What happens is this. People say, even at first, when I first learned this back when, well, wait a minute, if I break my arm, how am I going to get an infection in the bone if there's been no penetration? It's not like I had a compound fracture, just a regular fracture. How does that happen? Well, what happens is this. There's bacteria all over our body, right? There's bacteria in our bladder. There's bacteria in our lungs. We have the immune system that suppresses the effects of that bacteria. Bacteria are always looking for opportunities to proliferate, to grow, okay? Now, when you have a fracture, you have a decrease in your immune system because your immune system has to respond. And what happens is there's an opening in the bone. And through the bloodstream, those bacteria find ways to get into the bone and proliferate. So if a fracture goes undetected for a while, 3, 4, 5 days, there's a greater chance that you're going to develop or can develop osteomyelitis. And you don't want to, I had one patient that had osteomyelitis. They had surgery, then they had a fall, and they had a compression fracture in the vertebrae. And when they came in, extreme pain, crying, the pain was greater than the injury itself. They were throwing up. They thought they had food poisoning. I looked at her back around the scar. It was on fire. I talked to her mom. I said, I don't want to alarm you, but you need to go to the hospital right now. They went to the hospital. They put her in intensive care right away. Time is of the essence. Compartment syndrome. This is an interesting one too, not a thing you hear all the time, but compartment syndrome, what happens is if you have a fracture, you can have a breakage of surrounding blood vessels or even tears in the surrounding muscles. Typically in the compartment, so the compartment would be the lower leg, where this is a sagittal transverse view. That's the tibia. I'll probably get a little closer. That's the tibia, that's the fibula. And these are the different muscles and the blood vessels. That's the middle compartment, the posterior compartment, the anterior compartment. So this would be like the tibialis anterior. This would be the calf. This would be the tibialis posterior and the internal muscles there. If there's a fracture here, what happens, there's muscle swelling. The muscle swells, bleeds, and puts pressure on the vein, artery, and the nerve. And what happens there is blood is cut off, blocks blood flow to the extremities themselves, the distal foot. So what happens is that pressure needs to be relieved. And if there's an injury, so this also happens in muscle injury, which we'll talk about, we need to act fast. So if someone comes into your office, let's say they have a calf strain, they have compartment syndrome, and you're not sure, the compartment syndrome is going to look a lot like what? A DVT. And if it looks like a DVT, do we feel for the posterior tibial pulse? I would recommend against it, send them to the hospital. Complications of muscle injury. This is pretty interesting. Let's say we get a muscle rupture. What happens in a muscle rupture, a muscle tear? This is what happens. This is the progression. We get intramuscular swelling and bleeding, okay? And then potentially what this can morph into is what? Because this is in post-injury, there's a chance of deep vein thrombosis. There's a chance of compartment syndrome. This is typically, now we're talking in the lower arm or the lower leg. So it's just important to recognize that if there was an injury, let's say a beer league, they have beer leagues in Canada where they all go and drink beer after they play softball. And so let's say people who are not in great shape, maybe they have diabetes, they're obese, ill health, they go and they pop their Achilles or they tear their gastroc in their calf, and they come in and they're presenting with a tear in their calf. Oh, it hurt, there was trauma, but it feels hot. It's tender to the touch. It could be potentially one of these things. So always keep that in the back of your mind. I'm not saying everyone who tears a muscle is going to have a complication, but you need to be aware of it. With compartment syndrome, though, pain with deep vein thrombosis, they're not in excruciating pain. They're like, well, it hurts, it's hot, it's swollen. With compartment syndrome, the pain is not proportional to the injury. Okay, almost similar to complex regional pain syndrome. The pain is not proportional to the injury. But in that case, you refer them out. And again, physical assessment, pulselessness, but we don't really know the difference between DVT and compartment syndrome. We're not sure, even though people, let's say sports medicine specialists might be able to tell the difference. Our job is not to tell the difference. Our job is to detect a problem. My other one, this is an interesting one too, and you don't see it a lot, but blunt trauma to the muscle. What's blunt trauma to the muscle? Blunt trauma is just a square hit, okay? It's probably getting hit by a baseball. I saw this once, patient who plays baseball got hit by a pitcher, right? They threw the ball, hit by a pitch. And another time it happens is, I remember me when I played basketball, it happened usually in the thigh. It comes off as a deep bruise or a Charlie horse. And what happens is a lot of times in basketball, when you're driving to the hoop, right, a defender trying to defend you, you get a knee or an elbow to the leg, and it develops a deep bruise to the thigh. By the way, I predict this year the Los Angeles Clippers will be receiving a lot of Charlie horses, especially when they're playing Toronto Raptors when they're driving to the basket. So what happens is, what can happen? Something called myositis ossificans. So myositis ossificans is after blunt trauma, you get a calcification forming in the area of the deep bruise about 4 weeks after. And why this is important is because patients will come to you and say, I got this Charlie horse 4 weeks ago, 5 weeks ago, and it really hurts. And now it feels like a hard ball is forming there. I think the muscle is tightening up, right? But what's happened is calcific change. And the thing with myositis ossificans, the more we do manual treatment on it, especially right after the injury, the greater chance you have of creating calcific, you make the problem worse. You accelerate the calcific deposition in the muscle. So this is what you need to do. If a patient comes to you, a blunt trauma, all right, and the mechanism is a blunt trauma hit by a pitch, Charlie horse, kind of kicked directly, in martial arts, I took a shot to the thigh. The treatment is RICE, rest, ice, compression, elevation. No needles, no soft tissue work. For first 48 hours, the research shows, treat it with rest, ice, compression, and elevation. After 48 hours, then the research says we can do different things like muscle work, acupuncture, things to help improve blood flow to it. But even still myself, I would work around the area. Okay, I wouldn't go right into the area. I'm sure, I believe very common for traditional Chinese practitioners, they call it surround the dragon. That's one thing that's common. You know, when it's this sensitive and this acute, work around it, stick with rice, don't do any manual work to it. The other thing, and I've never seen this, but it's something that's typically coupled with myositis ossificans, is pyomyositis. So what happens after an injury, you get an infection in the muscle. And typically, this happens in people who are immunocompromised. And also, for some reason, happens in tropical regions. People in tropical regions that have a muscle injury and develop muscle infections. The reasons for it, I'm not clear, again, but our job isn't to know the reasons. Our job is to know if someone comes in, let's say with a muscle, say, oh, I hurt my leg 4 weeks ago, but I have a fever and I'm really sick and I don't feel well, well, maybe you should see your doctor, okay? Good. Okay, so here the last thing I wanted to cover before we get into the Q&A, the question and answer, is fainting and syncope. Fainting and syncope is not an emergency. Okay, it's not an emergency. It's happened to me 3 or 4 times in my career. Patients have fainted. Right? I'm sure it's happened to almost every one of you. And it's a possible side effect of not just acupuncture. It's a side effect of joint manipulation. I've had someone pass out from soft tissue work before. And it's not an emergency unless the patient remains unresponsive. And how long is that? Well, it typically, in my experience, when it happens, time is, it's hard to quantify time because you're so focused on helping the patient. I would say anything longer than 30 seconds, I would start to get concerned. But what you do is you stay calm, you protect the patient. If they pass out, you make sure you get them on the table or in a position where they can't hurt themselves. Remove any needles you haven't already and manually apply GV26. It works extremely well. Of course, many of you, everyone knows that already. But GV26, put the pressure down for 10, 12, 15 seconds. And as you have the pressure, they'll start to respond, okay? That's not an emergency. And what you do is you just, at that point, I end the treatment. Okay, and I get them some water, I get them comfortable. I assess whether or not they're able to leave the clinic and go home by themselves, or we need to call help like a family friend, whoever, a family member, friend, to drive them, right? Or call a taxi or whatever, right? We need to make that judgment call. So we want to make sure that once they're responsive, to assess their ability to leave without help. So again, because some people think, well, they passed out, that's it. It's not just stay calm. It happens. It doesn't happen a lot. Ways we can decrease that is, that's why I always have the patient laying down when I'm doing acupuncture. I never really have them sitting up. Of course, there are some cases where you need to have them sitting up because they can't lay on the table, they're elderly. You just want to keep an extra eye out for them in that case. And the predisposition to that is, how's their overall health? Are they immunocompromised? Do they have diabetes? Are they on a lot of medications? If that's the case, I tend to spend a little bit more time or a little bit more attention to making sure they're protected if I have them seated when I'm doing acupuncture. So that is that. So we'll get to the Q&A. But to conclude, understand, when you look at something, ask, what the heck am I looking at? What is happening? And you'll be able to recognize this is not something I can treat. I'm not sure what this is, but I need to refer out. I can't help them with that. So understand. And also understand that when in doubt, refer out. When in doubt, refer out. No one is going to blame you for referring them out if you're not sure, if you think they have an infection, a DVT, having a heart attack, a stroke. No one's going to blame you for that. But if you miss it, they're going to blame you.